Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential to successfully navigating today's rapidly changing business environment. Thank you for joining us, and we hope you enjoy this episode.
Welcome to the AUA Leadership and Business Podcast series. Today's title is Urologists Clinical Value to the Healthcare System. Today's topic is Understanding Downstream Revenue. I'm your host, Dr. Micheal Darson. I'm a urologist in Scottsdale, Arizona. I'm the prior chair of the AUA's Business and Leadership Education Committee. Joining me today to discuss urologists' clinical value to the healthcare system is Dr. Gyan Pareek. Dr. Pareek is a professor of urology at the Warren Alpert Medical School at Brown University in Providence, Rhode Island. He currently serves as interim chief of urology. He is also the director of the Minimally Invasive Urology Institute at Brown and director of the Minimally Invasive Urology Fellowship. He serves currently on the AUA's Business and Leadership Education Committee and has a keen interest in empowering urologists with necessary knowledge they need to value themselves at the highest level. Welcome.
Thank you very much.
Well, let's go ahead and get started. Dr. Pareek, why do you feel it is necessary that each urologist know and learn their own value?
Well, I think first and foremost, urology has become such an important specialty to the systems, just based on all the things that we do, from surgery and also through medical management of various disease states. And while we are providing all these services, I think it's important for us to know what those services yield, and in sort of downstream revenue, as we say. Often systems like hospitals don't like to hear words like downstream revenue, but I think it's important for us to know what we represent in a system. So if we can empower all the urologists to know that, hey, I do 5,000 cases, or 300 labs or 200 CAT scans, what does that translate into this for the system? And if we can do that, then I think it creates a really educated culture for us, which then allows us to retain high quality talent, recruit, and actually ultimately lead to advocacy nationally, which helps all the urologists all over the country.
Okay, very good point. How are urologists valued, and how does this value relate to downstream revenue?
So ultimately, urologists get valued in various ways. I think, when we come out of residency and we go into practices, we see contracts that have a number on it. Often we don't know, how that sort of number comes about. And so ultimately, I think that knowledge base is critical. And then as we grow in practice, we start contributing more, we get busier and things like that. So the value is defined in multiple ways. I think the main sort of source right now is what we call work RVUs. A lot of value is placed on this number, which essentially represents the amount of, let's just as it says, work you're doing. And there's usually a dollar amount attached to that RVU. And so initial contract negotiations, whether you work for a private practice, whether you work for a hospital, academic medical center, will often get defined by RVUs. So one of the main ways urologists are valued is through this RVU calculation. I think knowing your value is critical, because that allows you to actually assess whether that RVU calculation is something that's in line with what you deserve. Some good sources to find out that value are the AAMC, which is the American Association of Medical Colleges, if you're in an academic setting, versus the MGMA data, which is more, they also produce some academic data, but is more for the private setting. So it allows you to establish some benchmarks, and these benchmarks then allow you to sort of look back and see if you're valued correctly. Often these guides will provide an RVU analysis, and then and then say what the monetary amount of money, amount of money that's associated with that RVU. So it gives you a good idea. It tells you percentiles. And so I think, you can see where the 50th percentile, for example, is, and then work your way from there. And it also defines the value by region. So, you can actually look and say, okay, I live in the Northeast, and that market is different than the Southeast and the West Coast. And, market forces often dictate that. So, I think it's very important to know this data inside and out, because if you do work for a healthcare system, for example, they're going to use these benchmarks and create compensation plans and contracts based on those, as well as potential bonus structure. And so I think knowing that is very important. That the last point I'd like to make on this subject is that ultimately, and this is really if you work for a healthcare system, the discussion which you want to have with whoever is representing you in the group, or if you're representing yourself, is to understand the amount of dollars you're producing for that system. It's a very difficult figure to come up with. There are a lot of guides out there, reports that are produced, in various formats, but knowing that amount is critical. And in general, we use at our place, we use a little formula where it's about 2 to 3 times what the amount of money you sort of bring in revenue for yourself. So for example, if someone is making X, then you would multiply that by 2 or 3 times and say, okay, this is the amount of money that I actually bring into the system, and then it gives you the ability to negotiate a little stronger.
So does the work RVU, does that accurately represent the downstream revenue that you would be creating?
So unfortunately, work RVUs represents really the work you're doing and how hard you're working. It should match up in dollars, but often if you're, for example, in a poor payer mix area, or you're in an area where you're doing free care, you're still generating work RVUs, but you may not be generating money. So it's not always a direct one-to-one link, but certainly the receipts that come in with those work RVUs are a better measure, I think, to calculate downstream revenue. So, if you can get your total receipt and collections, then you can multiply that factor I mentioned earlier, and then be able to have a strong argument with the system.
Okay, that's a good example. I know we're going to get into some examples a little later of this, but let's use a pretty simple one. You're a private practice urologist. You see a patient for an elevated PSA, so you've got the appointment. It generates a biopsy, which generates a path of a prostate cancer patient, generates an MRI, and then it generates radiation. Can you kind of give us a concept of how that affects not
Sure.
only the RVU, but how it affects the downstream revenue?
Yeah, for sure. So obviously, all those things that you're doing in your office are billable services and are generating revenue, and they're also generating the RVUs, for which most systems are utilizing to judge productivity by. I think all the other things that you mentioned is really critical, because systems and organizations often will not put that in the same bucket when they're talking to urologists about compensation and things like that. So the things you mentioned, you generate a biopsy, that biopsy goes to the lab, and depending on your group structure, if you're a large urology private practice, that's obviously different than a hospital setting. But even for a large urology group practice, you then will generate fees, and those fees can be broken down in many ways. So, for example, in pathology, you'll generate a technical fee for the system, because they're processing those pathology slides, and that technical fee will be paid out to the hospital, let's say. And then you're going to generate a professional fee also. Once that is done, so now the hospital has generated a downstream revenue. So that's the buzzword, downstream revenue, because of something that you did. Let's say that patient ends up going to prostatectomy. Well, they would have surgery. The hospital generates a technical fee, so more revenue. And then let's say that person has adverse pathology and they need radiation therapy, and they go into the radiation scanner, or they get a CT scan, for example, to simulate, then that's generating downstream revenue. They get more labs, downstream revenue, and so on and so on. So that total value that a urologist has by doing that one biopsy, in some cases may just seem like, okay, well, I did a biopsy and this is the money I generated, and it becomes a very sort of isolated way to look at things. You should look at it that, yeah, I did this biopsy and then I generated all this value for the system. And so, it's very hard to capture all of that, but just starting small, understanding the principles will then lead to more and more sort of knowledge and empowerment.
So let's take two different examples. So you're a fresh grad out of residency versus a seasoned urologist with 15 years of education. So, or 15 years of experience. So just coming out, I mean, are you walking into a contract just asking to be paid on RVUs, or are you trying to establish that overall umbrella of the concept of downstream revenue?
Yeah, that's an excellent question. I think what you can work both ways. In my experience and the experiences I've had early on as a employee and then a partner, and now as the interim chief, and hiring and retaining and recruiting people, both models can exist. What we find is 90% of my experience has been that urologists will take a fixed sort of salary as the early grad, guarantee for a couple of years. And I think that's a different model than obviously an incentive-based model, which is more RVU dependent. I think fresh graduates are generally not expected right away to produce, at some level, because they're just getting started. And I think the general rule of thumb is, it takes a couple of years, 2 to 3 years, to get a practice really going. Not always the case in every region of the country, and it depends on if it's academic or private. The other model is that you can take a little less compensation and work for an RVU productivity model, which will then generate your bonus structure and things like that. And we have had a couple of instances where folks have signed on that way. I think, like I said before, the majority of fresh graduates usually work off a guarantee. As you get into more and more years of service, you then, will develop more of an incentive-based model, which is more the RVU-based sort of productivity model. And those benchmarks usually are set, as I said before, by the AAMC and the MGMA. And we use it at our place, use a little hybrid model, and you come up with, okay, these are the benchmarks you're trying to hit at the years of service. And if you hit, a certain RVU level, and then you go over that, then you can then get a dollar amount per RVU as a bonus structure. So a simple example is, you're expected to do 7,000 RVUs, let's say, for a certain amount of compensation. And if you go and hit 8,000 RVUs, then the extra 1,000 will be multiplied by a dollar amount, and that would be the bonus structure. So the folks that are more seasoned and out will generally, have contracts structured more in that incentive-based pattern rather than a fixed guaranteed salary.
So what I'm hearing is that there's no real reliable way to attach downstream revenue to RVUs. Is that correct?
That's correct. I would say that's an accurate statement. I mean, in general, though, if you're generating X number of RVUs, it's going to lead to more and more downstream revenue. Just a very sort of obvious conclusion of generating more RVUs.
I think that's certainly a key for our listeners in any future negotiations.
Yeah, for sure.
So let's talk about different revenue streams. Can you give our listeners an overview of different types of revenue streams? I know we've touched on some of them already.
Yeah, so I think a good acronym to know is NPSR, which is Net Patient Service Receipts. Those receipts are basically forms of, you see a patient, you do a level 3 visit or a level 4 visit, and then the amount of revenue that comes in for that based on your contract with the insurer will be one form of revenue, which is, a lot of it can come in that format in general. That's how we sort of make our money. But as the systems have evolved, and again, depending on the system you're in. So, for example, in an academic practice that maybe has other responsibilities like serving on committees, doing research, and things like that, you can also have contractual revenue streams. So, net patient is basically bread and butter urology operations, seeing patients, and that generates a certain uh, um, revenue, and that comes in that way. Then you can contract with a hospital and say, okay, we're going to do this program in research, or we're going to develop this reconstruction program, or this kidney stone center, and so we would like to have a contract with you to reward us for our services. And so those numbers, if we can call them that, come about based on fair market value for your time, and it's a negotiating process. So again, knowing your value is critical, and so you can set up. So in our place, we have a kidney stone center. I go there half a day a week, and that time is valued at X. And so that revenue comes into, let's say, Brown Urology, which is my group, as a contracted revenue. So now we have a line on our balance sheet that says NPSR. Then we have a line on our sheet that says contracted revenue. And then we also can develop, and get, as we discussed, depending on your group structure, if you have a lab, if you have pharmacy, if you have radiation oncology, those things generate what we call, as I mentioned earlier, technical fees. And so that revenue can come in and should be defined as another line item. So there's multiple ways, depending really on what model exists in your organization.
Okay. So let's use oral oncolytics as an example of those ancillary receipts. Can you kind of tell us how oral oncolytics and how that is an example of downstream revenue?
Yeah, so you can have again, it's sort of like developing a business plan with that. So, for example, if that oral oncolytic can lead to, if you have your own pharmacy, for example, and you have a championed sort of prostate cancer program, let's say, and you are able to sort of bulk purchase medicines, give them, and then generate fees from them, those that then leads to more downstream revenue. So it's not just the actual PSA check and follow up for that patient, but it's also you're generating a revenue stream of money from that sort of service that you're providing.
Yeah, when you really start thinking of downstream revenue, I mean, every patient is a potential downstream revenue event ready to occur. Like even overactive bladder, multiple visits, different medications, peripheral nerve evaluation, interstim. It's really amazing to think about how each patient can touch so many different areas downstream.
Yeah, you're correct. I mean, it's and you just want to make sure, because everything that you do, and the reason I think you stress the importance, and it's not just always, I want to make sure the listeners understand that it's not always about just making money, but it costs money to do things. We have cystoscopes, we have urodynamics machines, and we have drug costs, pharmaceutical costs, which is labeled in our expense report as a line item. So it's important not to lose money, right? You have to run a business. So I think it's knowing these different sources of revenue are critical.
Do you know if any of this type of stuff is taught currently in the residency programs?
So it's interesting you asked that question. I remember, I've been out now 16 years, and coming out, I remember I was, very aggressive with some of this stuff early on. I always liked studying, dollars to the healthcare system, see how much various things cost and so on. And I would bring up money at that time, and I would be looked at as like the devil because, money and medicine didn't mix. And my father was a urologist, and he, same thing. You could not talk money and urology, but the reality of the situation is the healthcare system has sort of led us to this, right? Because it's become so hard, and we're defined by this. And so, yeah, I think it's the teaching has become more. So now I just gave a lecture about 2 months ago on, it wasn't necessarily on this, but it was on personal finance. And so we're having this huge explosion in non-science urology. And I think that these podcasts and the AUA has done a good job, because I think these are great sources of information transference so that we can actually teach science in the residency programs and the teaching programs, and with a little bit of this non-science teaching. But yeah, in general, I think it's heading that way. In the last couple of years, it's changed at our institution. So it's being taught, in different formats, but maybe not specifically like this. But the residents are asking for it for sure.
I think it's a great idea. You guys are ahead of the curve, it sounds like. Let's talk about funds flow. Could you provide examples of different forms of funds flow?
Yeah, so funds flow is a buzzword utilized by every CFO or of any organization, and it's essentially passing of dollars from an institution or a hospital system to the providers. And so there's different ways you can do that. There's research funds flow. So if you provide research services, there's something called AS&T. AS&T is a acronym that stands for administration, supervision, and teaching. And so, for example, at an academic practice like ours, how our model is a little unique because we're not employed directly by the hospital. We have our own physician-led, physician-run organization. So when we contract with the hospital and say, okay, we're teaching residents, fellows, and so on, we want to get credited for that, and we then propose a certain amount for that teaching, and that comes in the form of AS&T. And it's a good way to make sure that you're legally exchanging dollars, because you have to be very careful with STAR clause and anti-kickback rules that exist. And so, for example, if we don't work for the hospital, then exchanging funds has to be done in a very specific way. So AS&T is one of those ways, and research dollars is another way. Medical directorships is another way for funds flow, where you provide medical services, like I mentioned the Kidney Stone Center earlier, or a multidisciplinary cancer center, where you may participate 1 day a week or something like that. And that allows for also funds flow in what we call medical directorships. You have to be very, very upfront. You have to be very compliant. These numbers aren't random calculations, and you have to follow the law. And that's the way the funds will flow. This sort of thought process doesn't exist in some ways if you work for the hospital, for example. They may not sort of flow funds this way. So these are very specific to maybe groups that are private and or hybridized like ours that then have to deal with the hospital. A good acronym also to know is CART, C-A-R-T. So we use that, which stands for Clinical Administrative Research and Teaching. And so that CART model is often utilized, and you can, basically use that to come up with a funds flow that's appropriate and that's also legally compliant, et cetera.
So you mentioned that some of these are not random numbers. Can you give us some insight on to how those numbers are generated?
Yeah, so it's almost like the way you can think about it is you can't add up over one, or you can't be in 7 places if there's only 5 places to be. So for example, if you're clinically active, and this is where sort of the RVUs come in, and as I mentioned before, it gets a little tricky. So if you know that, for example, 50th percentile RVU for a practice is, let's say, 7,500 RVUs. So if I'm generating 11,000 RVUs, then I'm 80th percentile, let's say. So if I'm 80th percentile, and then I then go try to negotiate for dollars for administrative research and teaching, and those add up to, like greater amounts, then what'll happen is it's almost impossible for you to sort of be that clinically busy and then that administratively busy, and so on. So what you generally do, and we all know we all work more than 40 hours a week, so it's tricky because that's what they use as the sort of the benchmark for hours. So you want to just add up those various tasks you're doing and then come up with a fair market value. I hope that was clear. It's a little bit of a complicated way to do it, but it's just, I think the basic principle is that if you're generating that many RVUs and that much revenue, then how could you be also doing research, for example, at that level? So I hope that was clear enough for our listeners.
Yeah, no, I think conceptually it's easier to understand the way you described it. So that was great. So it sounds like the future is bright for urologists. What do we need to do to stay strong and change in the complicated healthcare system that we deal with in an everyday practice?
Yeah, I think, like I said before, it's not always all about money. It's about practicing high quality, evidence-based medicine. I think, I'm proud to be a urologist. Our AUA is a really great meeting, for example. I like when you compare it to other meetings. I think it's first and foremost, practice the best medicine you can, and then educate yourself, as we discussed, on your value. And that doesn't come with just one reading. It comes with multiple sources, whether it's this podcast or something else. And I think it's continue to push the envelope with knowledge. We're great subspecialties with technology. I mean, tremendous models all over the country with quality practicing, pharmaceutical revenue, radiology, as we mentioned, clinical. I mean, urologists are just really unbelievably, I think, they push the envelope to the max in a positive way. And so I think the future is bright. I mean, one of the things that's happening is, as we all know, is I think the figure's thrown out there a lot. For every 10 urologists retiring, there's only one coming in. And so, this value discussion is critical because you may end up in a area that's going to value you at a certain level because there's just so much need for urology. I mean, in our state alone, I got a call from 3 different systems to help us staff their emergency rooms and so on. And it's very difficult, and I feel bad. But with somewhat of a shortage, I think the value conversation becomes even more important. So, to close, I think it's just a good time. The market's hot, and I think just practice really good medicine, as we know, and know what you're worth.
Great point. You also mentioned the AUA meeting. I would also say that the section meetings are really good. We're in Hawaii every other year. You should think about coming to Hawaii and giving this talk.
Yeah.
I think it's super informative.
Would love it. Thank you.
Yeah. A big thank you to Dr. Pareek and our audience for joining us today for this very valuable discussion today.
Thank you so much for having me. It was a really great discussion, and I hope our listeners get a lot out of it.
Absolutely.
Thank you for listening. If you enjoyed this episode, make AUA Leadership in Business your go-to podcast. Subscribe today by searching AUA Leadership in Business on your favorite podcast app and enhance your leadership and business education needs.